Good morning, everyone. Thanks for joining us on what will be the last of our first series of One Medical Group webinars for primary care networks. Today's topic is population health management for primary care networks. And we're delighted to welcome along three guests who are going to help discuss and debate the topic with us. As always, there is a questions box, so if you want to ask any of our panelists questions during the next 30 minutes, please do feel free to pop your question in the question box. If we can't get through them all, we will provide written responses out to everybody after this morning's session, so please do feel free to pop your questions in as we go along. So let me introduce the panel that we've put together for this morning's discussion. So we have Dr. Manjit Purewal, who is a GP partner and also works at One Medical Group as Director of Quality and Improvement. We've got Dan Carter, who is Head of Business Intelligence at One Medical Group. And we're delighted to be joined by Chetan Moda this morning. So thank you, Chetan, for finding the time to come and join us. Chetan is Head of Population Health Management and Strategy and Transformation at NHS South Central and West CSU. You've got a big title there, Chetan. So I'll let our panelists tell you a little bit about themselves before we start. So Manjit, would you like to tell us a little bit about you and your background?
Sure, certainly. So as Caroline has said, I'm a jobbing GP for half my week. So I'm senior partner in a large practice which has grown over the last 17 years that I've been there, from 7,000 to 22,000. We are still growing, and a lot of that has come through work that we've done with our sort of population and understanding what their needs are and what services are we providing for them. For the last sort of 12 years, I've done some work with the PCT and then the CCGs. I've been clinical director for Leeds North CCG, and then in the latter stages became the clinical director for quality improvement. I left the CCG at the beginning of this year and joined One Medical Group in April as Director of Development and Improvement. Part of that reason being I recognise that a lot of the stuff that we do is based around assurances, or based around ticking the boxes and making sure that we get paid. Essentially, a lot of the box ticking results in our payment structure. However, we seem to get stopped at those levels. A lot of people stop at that level rather than actually saying, how do we do improvement, which means that we can go above and beyond stuff, but make sure the boxes are ticked in the process as well, rather than it just being a box ticking exercise. So I like to challenge the status quo. And from a personal perspective, being involved with population health manager, Leeds were heavily involved 2014-15, and it was Leeds North that were leading it. And that really came from the agenda of integration, about how do we integrate all the various different providers in the system together. And I'll talk about that a bit more as we go through the questions. So I'll pass back to you, Caroline.
Thanks, Manjit. Chetan, would you like to introduce yourself?
Yeah, sure. My name is Chetan. I'm Head of Population Health Management for South Central West CSU. I've been involved in analytics and BI and data, and more recently risk classification and population health solutions, probably for the past 15 years or so, both within the NHS and in the private sector, running services back into the NHS. And really, I'm currently responsible for a team in the CSU that look after the kind of population health management needs for a range of customers across our CSU footprint, across the south and west, yeah, just really keen to kind of maintain this interest there is in population health at the minute. So it's a really exciting time for us.
That's great. Thanks, Chetan. And last but not least, Dan, tell us a little bit about your background and your role at One Medical.
Yeah, good morning, everyone. So I'm Daniel Carter. I'm Head of Business Intelligence at One Medical Group. So my team provides services to One Medical Group and One Primary Care, which is the health side of One Medical Group. We do everything from contractual reporting to more in-depth health analytics. We also do some work for support work for PCN, so really focusing on population health management, helping them understand their patient group and how population health management can help and drive their services. So I've been in healthcare in the NHS for about 2.5 years now, but I have a background in retail banking. I've held lots of different roles, technical roles, but I sort of retrained about 2.5, 3 years ago in data and data analytics, because it's kind of my focus and my interest. And that's really what I'm interested in, identifying tools that can help the healthcare better serve their patient group, and really not making data scary. I think it can be scary, and I think that's my job, to really simmer down a lot of information and share it out to people and get them to sort of seal the bullets of what they need to know.
Thank you, everyone. Thanks, Dan. So population health management is today's topic, and as always, we only have 30 minutes, so we can only really scratch the surface of the topic. But I really want to get a flavour of what what population health management means to primary care networks, and where they can start on that journey if it's not something that they've already started exploring. We often talk around trying to manage the patient's health and well-being holistically, and a population health management approach can help to do that, because it's less focusing on the care that patients need, but the socio-economic holisticness of patient care as well. So wrapping all the services around them, really understanding the needs of our patient population. And Chetan, I know as we talk and we go through, you'll touch on patient segmentation as well, and provide some examples of how that works in general practice. Manjit, I'm going to come to you first of all. So from a GP, from a jobbing GP and a partner's perspective, talk to me around what population health management means for you in your practice, and then where PCNs fit into that.
Okay, thank you. So, I mean, the first thing I would just say, it's really interesting. I would suggest that people just Google population health management, and particularly put the NHS with it, because you'll find that its definition, even the NHS struggles to actually really define what it is. You know, for example, some people define it as a tool. It's an emerging technique for local healthcare partnerships to use data, and others describe it as being at the heart. It's about enabling people to live healthy lives. And I think it's a combination of all of these. And I would absolutely say it's not an emerging technique. It is stuff that we have talked about for years and years and years, but probably not called it population health management. So I can remember just going back to a presentation about 15 years ago from a GP based in Bradford. And he talked about looking at why were they so busy with their appointments and access. And one of the pieces of work that they did was to look at who their frequent flyers were and how could they manage them in a different way and be more proactive. And in essence, what they started to do was just to actually contact them on a regular basis, so proactively contact them, which meant that the clinicians felt happier because they felt more in control, and the patients felt happier, and it actually resulted in improved access. And for me, I think that's partially what drove us as a practice to drive our access. Basically, you know, the patients do bring funding, they do bring money behind them, so just working on our population was really key, and understanding where we needed to grow and where we needed to provide different level of services. So we all know that we are constantly firefighting our same-day services. It seems to take over everything else. So you have to basically be a bit brave, step back a little bit, and introduce some change. But you've got to use data. I mean, I'm going to really advocate this, because I know we introduced telephone consultations back in 2005. Lots of practices came to have a look at it. It was a new thing for us in Leeds at the time. But a lot of people then went on to try it. But what they didn't do was to spend the 3 or 6 months that we had was just to look at the data. What was the number of telephone calls coming in each day? How were they spread? What was the age bracket of their populations? And what were the needs of those people as well? And that absolutely determined what level of service we were going to provide through telephones, rather than it being a typical NHS thing, which is we just do the same thing for everybody all the time. And so I would say that's our main driver. So I think, so I think that's probably where it's really helped me in my primary care, and it's resulted in our growth. We've not merged with another practice, so our access has truly just grown by the level of service we provide and our data. And our data is driven the appointment system and how many appointments we need each day for urgent, same day, and for routine stuff as well. But it's also led us to shift the workload to other people. So our nursing team now totally with a pharmacist now manage long-term conditions. We've got a paramedic who's starting to do other things, and social prescribers. So it's just started to shift the work, but that's come through the data and understanding what the population actually wants as well. And I should just finally just reiterate, I mean, I'm based over 2 sites. I'm based in a very affluent, leafy suburb of Leeds, which is, high demand for very different reasons. And 2 miles down the road, we've got another one, which is in the most densely populated part of it, with the most diverse population, with very high asylum seekers. but the same rules apply to both populations, but slightly different needs, and what we provided was different between the two sites. So that was really key as well.
Manjit, what do you see the opportunity being for primary care networks, so for groups of practices that are going to look at taking a PHM approach?
So I think the opportunities are that as you grow, as the population is growing, it's easier to look at the data sets because you've got more people to look at. So most PCNs are sort of 30, 50,000 population. So when you've got that sort of level, you can then start to really look at what their needs are. And I think in particular, start to think about what your workforce needs to look like going forwards, because we are traditional. We tend to, if a GP leaves, we tend to replace with another GP, or a nurse leaves, we tend to replace them. I've been involved in a number of conversations, say, with the PCN's workforce development, and a lot of it is people are just recruiting pharmacists or paramedics just because others have done the same, or nationally we're being told to recruit, but actually not thinking about what is the actual need of them, what are they actually going to do, and what bit of our population group. And we don't often change, we keep on repeating the same thing and same thing. So I think your data sets are much richer and much bigger if combined. So I know in Leeds, when we introduced PHM back in 2014, our first step was to look at integration, where we started to look at all the providers, so the acute trust, the mental health trust, the Leeds City Council, the voluntary sector, and primary care, and brought everybody together, and everybody then started to share their data, and that data set was incredibly rich to help segment the population, which I'm sure Chetan will talk about in a little bit as well.
Great, thank you, Manjit. I'll neatly segue onto Chetan then. So you're working at scale, Chetan, as a CSU, supporting multiple primary care networks with a PHM approach. So what do you see in your experience the benefit being for PCNs if they take that approach to managing services and workforce development?
I think firstly, I'll start just by echoing what Manjit has talked about. This is definitely not a new concept. I think the idea of population health as a thing that's more recently been talked about is slightly different to maybe some of the approaches which have typically been very locally led historically, whereas now there's a real kind of national push for everybody to work in this way, and I think that's what feels different about the current drive for a population health approach. But yeah, in the CSU, we cover a fairly large footprint with my service. We're supporting 10 CCPs, about 350 GP practices, and covering a population of about 3.5 million. So yeah, there are a number of PCNs in our patch that we support. I think that the kind of key thing for PCNs to kind of bear in mind with this is that it's really about a mindset. It's not a thing that you can do at the beginning and then kind of forget about it. It's really about how do you approach solving the problems that you're not only facing now, but how you will approach solving problems that you will face down the line that maybe haven't surfaced yet. But I think also it's about kind of pulling in the same direction. I think if you're working as a PCN, clearly there's a big part of it is an economy of scale. It's probably not the same economy of scale as if you're trying to operate it across an ICS, for example, but on a smaller scale, there is still benefit in trying to do things consistently. And I think it's about being clear about being challenged as well. So through this approach, you might have some assertions that you've had in the past challenged, and I think it's about being brave enough to accept that maybe historically some decisions were made on information that wasn't complete, but there's a real chance now for PCNs to really get off on the right foot, particularly around workforce planning. There isn't necessarily a direct link. You might think, oh, how's the population health approach going to help me manage my workforce needs, but actually, if you understand the needs of your population, it might mean the difference between employing a GP or employing a GP with a special interest around diabetes, for example. It's that kind of nuanced kind of information that you will have available to you, and it'll be evidence-based. You'll have the data to kind of support those decisions. So So yeah,
that's great.
I think
Thanks,
Chetan.
I'd like to, if it's all right, bring Dan into the conversation at this point, because Dan, I know exactly what Chetan describes around using the data to inform workforce planning decisions. You've been doing that with a number of primary care networks. So would you mind sharing kind of your experience and how you've got from kind of A to Z with those PCNs?
Yeah, so my work at the moment, certainly with PCNs, has focused on really looking at what they can do in their kind of emergent form with their Rs roles, so the additional role reimbursement scheme. So the PCNs we've been working with, we start depending where they are at in their journey, and that's something that PCNs need to understand and how we can help them, is looking at what do they currently understand from their data. Have they segmented their patient population in any way so far? Have they looked at their sort of population makeup in terms of demographics, wider health determinants, and long-term conditions? So that's where we've supported by producing data packs focusing in on those sort of 3 areas, seeing what the population is made up of, and currently, and Manjit and Chetan touched on, and currently how that population is using the service. There'll be a lot of assumptions made on, well, we believe patient cohort X with this long-term condition uses the service, but when you actually look at the data, it might be a very different story. You're also, the support we're doing is looking at PCNs and really trying to align what they're doing. Obviously, PCNs will be made up of several GP practices, which might have worked together, but probably traditionally haven't worked together, so have worked slightly differently. So what we do with them is not only look at their current data, but also what support they need to do to align that data. Data quality and accuracy is key to helping PCNs and other systems understand what their population looks like and how that drives services. So once we've understood the population and the PCNs, they've made decisions on what Rs roles they'd like to go ahead with. We're at different different stages with different PCNs. Some have taken on the new Rs roles and they've kind of been in for about 3 to 6 months. Some are still sort of at the start of that journey. But certainly the ones that now have social prescribers, mental health workers, dietitians in place, the next stage is really to wrap around bespoke dashboards and data to monitor the impact of those roles. Really what we're trying to do is come up with bespoke tools to focus on that PCN. There is a lot of data out there, but it can be quite generic. And the journey we're trying to take them on is going from a brand new role that didn't exist to putting that role into place and then seeing its impact. And that's key, because then you're always, with population health management, with business intelligence, the more live it is, the more data you have, and I think Manjit touched on this, the wider that data set becomes, you can be a lot more proactive with how you're dealing with any new role, with your population health, and you can make those decisions quickly. And that's really the journey we're taking the PCNs on, helping them work at scale and helping them understand their data better and make those key decisions.
And I think it's worth touching on, and I know that the 4 of us together have had a kind of a pre-conversation around the data that's available, that's out there. So there is kind of, you know, open source data available to practices and to PCNs in terms of the PHE fingertips data, the right care data packs. We're not short on data in primary care. I think often, you know, there's a saying that says, you know, we're data rich but insight poor. So, you know, often at PCN meetings we see, you know, reams and reams of data being shared. But actually the question is, what is the data telling you? What are the key points and the insights that we pull out of that data that then go on to inform the choices that we make as practices and as a PCN together? Manjit, I want to move the conversation on to you, because I've asked you all to think about sharing an example of how you in your practice or with partners or PCNs that you've worked with have used a PHM approach. So a real granular level example that you can share with us. So Manjit, I'm going to come to you first.
Okay, so I'm going to use an example from within the CCG and across the city of Leeds. So I mean, I think just to go back a little step, I think the first thing we've got to look at when you're looking at data is just to be curious. I think the key thing we've all got to learn is to just to be a bit more curious and not let the data necessarily lead the conversation. Think about the question. What is it that you are really intrigued to? A great document which we will share with you after is the NHS Confederation have produced a simple guide to population health management for PCNs, and it just says reflect, think about what's going on for you. So for us in Leeds, so we started the whole population, as I say, back in 2014, 15, and this was more about integrating people together and the techniques and the emerging sort of document. The Leeds blueprint was created, which is used in the flat pack stuff, which we will share with you as part of this. So one of the things that emerged was, obviously at the time, frailty was the big buzzword that was also emerging within the whole system. The whole NHS was suddenly referring to frailty, as was the social care services. And we segmented our population to 8 segments, and one segment was frailty. At that point, Leeds was divided into localities. So PCNs didn't exist, but it did have 13 or 14 localities at the time. And we started to just look at the data within each locality, or supported their localities to start to just look at their data to say, why were their population labelled frail? And what actually emerged from there was that if you lived in one segment, which is the northeast of the city, your reason for being labelled frail was down to your mental health. It was more down to mental health and memory issues, so dementia, for the main reason for you being labelled frail. Whereas completely opposite end of the system, in the Leeds southwest of it, the reason for being labelled frail was down to your mobility, down to falls. So that actually meant that just getting that granular data meant that the services that were then being commissioned for those 2 localities were very different. So in the Leeds, in the northeast of the city, more memory services were commissioned, and in the southwest, sorry, it was more physios and OTs. Whereas traditionally, having been involved in commissioning, if we suddenly felt that, oh, there's memory issues in the city, we just employed more memory services for the whole city, which meant they just got absorbed into the whole city sort of mantra rather than actually being appropriate for that niche market. So this is more about, it becomes more niche to say we're providing what is needed for that community. And there was differences. So when I left, these people were being recruited and the services being filtered down to that level.
That's great. Thank you, Manjit. Thanks for sharing that. Chetan, I'm going to come to you next. So have you got an example of a PCN or a system that have taken a PHM approach and what the results have been?
Yeah, we did some work with an acute actually, who approached us on our patch. They had done some pre-work and had identified their kind of top 5,000 high-cost patients that they wanted to sort of proactively manage on a kind of population health basis, and tried to understand how they could manage that cohort specifically. They approached us because they knew that we were kind of had some expertise in that area. We went in and had an initial conversation with them, and it was kind of clear to us from the initial ask that actually the approach that they had taken, although a useful start, wasn't necessarily a population health approach, and wasn't necessarily going to give them the answers that we knew that they were looking for out the other end of the exercise. But the kind of challenge was to kind of convince them that there was another way, and the other way was going to give them a much more better result. So through the tool and through the analysis that we were able to carry out, we were able to kind of take their identified patient cohort, which was purely based on prior cost alone, and we know from work that we've done in other areas that where you pick a cohort based on cost alone, you get a lot of false positives in there in terms of how appropriate proactive management is for them, because there tends to be a larger percentage of that cohort that have had single acute episodes. So broken legs, broken arms, that type of thing, and a relatively younger population as well. And trying to proactively manage that cohort of patients is not going to bear as much fruit as the cohort that are multimorbid, frail, etc. So fortunately, within the tool, we were able to give them a side-by-side comparison of their approach versus an approach that we'd recommended to them. Within our tool, we have a predictive marker that's known as the risk of persistent high cost. So that describes cohorts of patients that are likely to be high cost over a period of 3 consecutive 6-month periods. And what we were able to show them that actually that segmentation approach gave them a much a higher percentage of the population that were multimorbid and actually could benefit from some early intervention. And we ran a workshop with them where they brought in the clinical directors for their PCNs and for their practice GPs as well, where we reviewed samples of patients within that workshop setting, which then resulted in a series of reports that filtered down to those practices through the tool, which meant that they could identify those individuals, at a click of a button, sort of thing. So that was a real kind of interesting piece of work that started off at one place but ended up something a bit different. But the results were.
And it's nice to kind of hear the evolution of that journey as well. And Dan, I know that's something that the kind of the evolution of the journey is something that you've been on with a number of PCNs now, which is around maybe the question that we're trying to ask in the first place might not be the right question. So I'm going to change the question for you slightly in terms of what your learnings have been and on that journey of evolution that you've been through with PCNs, maybe what the biggest learnings and reflections have been.
I think everyone's kind of touched on it a little bit. I think the question, the be curious and what is the question we're trying to answer is the key thing, but equally keep an open mind. My key learning, I think, and this is just coming from my background in work, but coming into the NHS, and I think both Manjit and Chetan have alluded to this, is 2 key things. It's data accuracy is a massive thing in the NHS. I think we all work in similar ways, but potentially in silos from a business intelligence and from a data analytics perspective. So we as a group of business intelligence teams and analytical teams are always trying to find ways in which we can share data better across patches, and that will massively impact the work that we're trying to do with PCNs and how PCNs work. Because if you look at that in a microcosm within a PCN, I think I alluded to it earlier, you're dealing with GP practices which have been standalone for a long period of time. They might have worked in localities, they might have worked independently with CCGs, but now they are working together. So that data accuracy and data quality is absolutely key to going on that journey, and that's something we can identify from population health. Different people with different stages. It's something we've learned internally. So that's one of the key learnings for me, and it's understanding how live is your data and how accurate it is. And really what we're trying to do with that is the more we understand those 2 probably key things, how data sits within its context and also its accuracy, we can take that data and apply it to real world situations and be confident of it. That is always the key message, is how confident are we that that data is driving the right messages.
That's great, thank you, Dan. One of the questions that we get asked regularly through the contacts that we have with PCNs is where do they go to access this type of support, because it's very rare that PCNs have a BI member of their PCN team. So first stop, go and speak to your CCG teams. They have BI teams. A lot of CCG BI teams do focus on the contractual and performance monitoring of contracts, but there are CCGs across the countries that have got really forward-thinking BI teams that are doing some really exciting stuff around PHM. CCGs may also be able to link you into the CSUs, Chetan and his team as well, who offer services available, as did Dan and his BI team at One Medical Group, and both Chetan and Dan have been supporting systems and PCNs at scale. After this morning's webinar, we'll send you some of the documents that Manjit's referred to and some examples of the work that Dan and Chetan's team have produced for PCNs. And we hope that that gives you a flavour of how those reports can start to steer some of the decisions that you make as a team. That's all we've got time for this morning. Thank you so much to our panel for joining us. We're taking a break for the Christmas period, but we'll be back in the new year. So the 13th of January is our next webinar. Thank you to everyone that's been tuning in and has provided us with some feedback. Based on your feedback, we're changing the time, so they won't be breakfast webinars anymore unless you want a late breakfast. Our new time will be 12:30. So we'll be back on the 13th of January at 12:30, and we'll be kicking off the new year with a webinar on managing stress and staff well-being. We know Blue Monday is the Monday after our webinar, so hopefully we can give you some top tips on how to keep your workforce motivated and ready to start the new year. Enjoy the festive period, everyone. Best of luck over the winter season, and we'll see you next month. Thanks, everybody.
Thank you. Bye.